So, hey, Wally, can you just tell us what the radiation oncology community is doing now to take this field forward? Are there trials underway now, or the ones you're involved with, or part of the groups you're affiliated with?
So I'll talk about a couple of trials in stage 3 disease in general, and then specifically with checkpoint inhibitors. One area that I think is very interesting is doing what's called adaptive design studies, where you actually use what happens to the patient during the course of the trial to influence what you do. We finished enrollment in Energy Oncology, RTOG, of an adaptive design trial where we got a mid-course PET scan and were able to modify the radiation field based on a response to a 3 or 4 week PET. And we don't have the data, but what we did demonstrate is the ability from multiple centers to actually do that. And it could be that those patients where there's a shrinkage would allow us to actually dose escalate those more safely than we could in PET non-responders. So that's pretty interesting. There are trials either that are ongoing or in design where we're taking this landmark Pacific trial and using that as the background in the control study and adding checkpoint inhibition during radiation. It really has to be done carefully. It has to be done with sort of dose-limiting toxicity studies before the full randomization takes place. And finally, I agree with, regardless of the fact that induction chemotherapy never added much to concurrent chemoradiation, I still am pushing for the idea of checkpoint inhibition as a window of opportunity for those patients with stage 3 disease who are not so symptomatic that you feel you're risking something by not starting radiation on day 1. I think we could get some of the same exciting data that you're talking about in the operable patients.
Mm-hmm. Yeah. The one thing that we've learned in the neoadjuvant trials too, though, is the lack of a strong correlation between imaging studies and pathologic response.
Yeah, right.
If you're going to look at what happens to the lesion in these patients, you have to be very, very careful, because we've seen very profound pathologic responses, no question of response, yet no improvement on CT and no improvement, or sometimes even increase on PET scans.
Right.
So be very careful there. You mentioned about using your PET scan to help hone in on treatment too. I believe there was some older literature that the PET could somehow be influenced by radiation. Is that true, or is that debunked at this point?
No, that's true. But if you're looking at a 3 or 4 week PET, you don't get usually the inflammation. So if you have a 30-day gap between PET 1 and PET 2, you're really going to be looking at biologic response and not the inflammation associated with it you might see within 6 weeks of the end of chemoradiation.
Mm-hmm. Okay. Jyoti, your thoughts about other trials moving forward in this space, or questions that you would want to see answered?
So certainly, I think we talked a little bit about surgery up front, but can we intercalate surgery into this paradigm? So are there patients, because half of all patients with resectable stage 3 disease get chemoradiation in the country, right? It's regional or site-specific. It's not, we don't have the best answer. But would there be a scenario in which we treat patients with chemoradiation and then they undergo resection, and then they are treated with immunotherapy? There's an ongoing study through the Hoosier Cancer Network that's looking at pembrolizumab in that setting, allocating appropriate therapy to those that were not in this trial. So unfit patients or patients with comorbidities, I think, is a huge unmet need. Because if we look at traditional, and this trial again was a little bit different because patients were randomized after treatment of therapy or after concurrent chemoradiation. But if we look at the proportion of patients in the United States with locally advanced disease who are eligible for our current clinical trials, it's a minority still, who have pristine pulmonary function and performance status and lack of weight loss. So we're really looking at a subset of the patients that we need to do better for.
Yeah, just a caveat to those thoughts. The first is, I'm still unaware of any evidence that an induction therapy of any kind makes unresectable people resectable. I mean, that is, people have said this, but there is no data to do that. And I think I would be very, very careful in 2018 to have a multidisciplinary decision and to make a clear decision whether somebody is resectable or not. And if a patient is resectable, they're resectable that day. And if they're not, they should get concurrent chemoradiation, because for you to be faced with somebody after some induction chemotherapy and then have a decision not to proceed with surgery, I believe that compromises your ability to deliver a curative dose of a curative therapy program. And I'd be really, really careful about that. Again, coming back to the need for multimodality discussion and a clear multimodality plan. I see these cases all the time at our tumor board. People come to our place from other institutions, and that decision-making process hasn't happened. And I can't emphasize enough to put your team together and work something out, make up a plan and stick with it. Obviously, the condition can change, but the overall plan shouldn't change.
But having clarity early on, as you're describing, I think is very helpful to the patient and his or her family as well.
Absolutely.
Yeah.